Hello, listeners. This is Yukta speaking, your host for today's episode, which is a talk given by Rohit Ghosh, founding member of Qure.ai, on the topic What It Takes to Build a Real World AI. This talk is a part of the 12th IC Innovator Club virtual meeting hosted on the topic What It Takes to Do Real World AI Lessons from Deployment. Let us hear from Rohit Ghosh.
Hi everyone, this is Rohit here. I'm one of the founding members of Cure and the Chief Strategy Officer. Really happy to be invited to this week's meetup and definitely looking forward to contribute with whatever little knowledge that I might have on the topic. So the idea is that there is a lot of questions that we want to understand and answer in terms of what happens in an on-ground scenario, right? When you're trying to deploy AI on ground, what are some of the actual challenges that you come up with, right? So, and today Cure, we are deploying this almost across 50 plus countries, across 500 plus hospitals in US, UK, parts of Europe, Africa, a lot of it, Southeast Asia, a lot of it, Asian region. So there's a lot of variety of geographies that we have deployed in and understood different technical challenges. The idea of the session is just to bring out some of those learnings for everyone's benefit, right? So without further sort of, ado, I'll just quickly jump on to some of the very interesting questions that have been asked to answer for this panel. So the first question is, do you need to expand on data set for training? Can you elaborate on challenges here? So yes, data set for training is the most critical thing for any AI company. At Cure, we are almost crossing close to 4.2 million images for chest X-ray algorithm that we have built, right? Which is the most popular AI algorithm that we have. And that kind of a data is extremely important because if you honestly, I don't think AI is not something that is a lot of it is function, is a lot of it is because of algorithms, because the algorithms have become standardized over a period of time. Honestly, what makes difference today is, I think, the amount of data that you use for training, right? Because the more and more data it sees, the more and more accurate it becomes. Obviously, the jump in accuracy from when you are 90% accurate to, when you become 95% accurate with the same amount of data is much lower. So obviously, as in more the AI becomes more and more accurate, the delta improvement takes a lot more data. But having said that, every amount of data does count. So the second question is, how do we measure the completeness of the data, right? Representation of patient groups as such. Again, very important point. And honestly, at this point of time, the more I've understood this topic, I think this very difficult to now actually answer this. I mean, if you had asked me, let's say 5 years back, I would have given you an easy answer that you can just do random sampling or collection from natural data set where patient groups are uniformly represented. And if you do that, you should be able to assume that you have a complete data set. But the more and more I have seen real life problems, it becomes more apparent that a complete data set is a theoretical idea. I don't think you will ever get to a complete data set per se. What you do get to is something where you sort of, data set that are large enough to sort of accommodate for every sort of geographical variation, demographic variation, disease variation, seasonal variation. So there's a lot of trains that is there in the data. And honestly, the answer to all of that is just more and more training data, right? That's what I was telling in the previous question, right? That if you collect huge amount of data, you would more likely to be sort of there in terms of completeness of the data, but it's very difficult to theoretically go after a complete or define a theoretical limit of complete data set. Just try and collect unenriched data from as many different settings. And if you keep on doing that for over a period of 4 or 5 years, I think you will definitely get to a point where it would seem at least practically complete. The next question is ground truth of your training data set. How objective is that? What can you do to improve the quality objective of ground truth? This is again a very interesting question because AI, if you look at from a computer science point of view, AI is very difficult to train if you don't have an objective ground truth, right? All our AI algorithms are trained on that objective reward functions, where it's supposed to be, where you have a differentiable loss function and all of that, right? So you definitely need to have an objective function. Whereas if you look at real life reports are, or ground truths are not really always as objective, right? For example, radiologists a lot of times, right, in their reports as differential diagnosis, or sort of they would make something like a comment like bleed, and then they would put something like bracket question mark, right? So they are themselves not sure, so they put a question mark, which is, and then they would say please correlate clinically, right? Which means that if a doctor is sort of seeing the patient in real life, then they can obviously judge whether there's actual bleed or not, right? So this is how radiologists in real life hedge their decisions, right? They don't actually, not always sort of take a complete objective ground truth. But if you have to train an AI algorithm, you need one. So how do you solve that problem? What we have done is obviously come up with um, different mechanisms, and you sort of uniform standardizing ground truthing mechanism. That way, for example, every report that is looked at by a panel of radiologists instead of a single radiologist, because that way the ground truth is a lot more robust instead of relying on a single radiologist. Apart from that, if you have, a lot of times the radiologists would refer multiple things, multiple terms for the same finding, right? So if it's a disease, if it's a bleed, they would say bleed, hemorrhage, so on and so forth, right? So make a complete NLP, natural language repository of all terms that they would normally use to represent such findings. And that ontologies then you sort of use consistently across multiple disease areas. So just standardizing that process and making multiple, instead of one read or one sort of human read there, if you sort of do multiple reads, I think that's one way to sort of counter objectivity, or counter the subjectivity that you would normally get from physicians. Quickly jumping on to the next question, the result that your system provides, are they explainable, interpretable for a clinician? Do you have a method to visualize, explain them in a better user interface or report? Very interesting question. I think explainability is a very interesting topic. That's a core of machine learning or AI research as of this point. But if you really ask me, and I thought that explainability was very critical for human readers, right? I mean, for physicians, when they're building or trusting an AI algorithm, they need to understand why is AI making that decision. And the more and more I have sort of delved on ground and talked to a lot of physicians, it seems like explainability is firstly not that big a factor. To some extent, I think radiologists already know what it is, right? And they are all sort of just looking for those, those edge cases or stuff like that where they're not very confident. And very few, for example, if you say that there's a bleed in the brain, right? A lot of times, if you just say that, they already would be able to find that where it is, right? They were all, or possibly they already saw that and they were just not confident about it, and they needed an AI to help there, right? So a lot of times, firstly, explainability is not that big a factor as we normally understand in AI research as such, right? So in AI in healthcare research, explainability is slightly possibly lesser because clinicians already understand where they're coming. I'm talking about AI in medical imaging at least. But having said that, in terms of explainability, what we have done is specifically is what I told you earlier, right? That we thought that a clinician, if the AI is saying that there's opacity in the lungs, then the AI needs to point out where that opacity is, right? It's as simple as that. So every algorithm that we have, or every product that we have built, sort of produces that secondary capture in radiology, right? Which is basically the actual image with the overlay of the AI findings on top of that. So which actually points to the which region of the brain or which region of the chest X-ray that it's looking, which it thinks is actually the cause of concern, right? And it marks that out saying that this is the opacity area, this is where it's found, the nodule in the lung. So that is very important, we felt. Obviously, more and more people are now getting used to AI in imaging, so a lot of them are fairly acquainted with this kind of interfaces, and it's a lot more easier for them. So I think, but those basic level of explainability is definitely important, I think, for people to understand how the AI is looking at that decision, right? The next question that I have is, what happens when the AI and clinicians do not agree on prediction? What happens? Do they give a feedback? Yes. There are a lot of scenarios where AI do not agree with the physicians, or, the AI, or possibly the physician agrees with the AI, but not on the first read. I mean, possibly they look at something, then they see the AI results, and then they figure out, okay, yeah, possibly there's something that the AI has picked up, which they missed. So in those kind of setup, yes, there's a discordance that happens. What we definitely use is, if we actually, again, as I said, it's very important to have a very robust ground truth. So just because one radiologist does not agree with one AI output does not mean that the AI is incorrect. So what we need to do in those kind of cases, what we do is basically go for what we call a discordance meeting, right? So every hospital that we deploy, we have this monthly meeting of sorts, which is called the discordance meeting, where we look at all the discordant cases, right? Where one single radiologist did not agree with, let's say, AI. And those cases are accumulated and those are reviewed by a panel. Again, it's important to have a panel look at it because one radiologist can always miss out case or they think they could be incorrect, right? So it's important to have the panel review it. And if the panel thinks that there's something, for example, the AI has not picked up or has marked out wrongly, right? It's a false positive or a false negative. In either of those cases, the cases are sort of accumulated over a period of time used for retraining the algorithm. It's not deployed on the go. I mean, as soon as the AI is learned from the new case, it's that newer version of the AI is not deployed because there are a lot of regulatory hurdles. But over from one version release to the next version release, right? One regulatory version release to one next regulatory version release. We sort of collect all these discordant cases, train the AI on that, and then we release all those cases, all the newer version, right? So that's how we sort of do the discordance mapping. Next is how do you bring feedback on the performance of your system in the clinical setting? This is something as I already explained. So there's a proper process in place, which is called a discordance meeting. And there's a post-market surveillance for every CE or FDA regulatory body that you get approval from your algorithms. You have to follow a post-market surveillance where there's sort of a proper survey of all the discordant cases and, cases where the AI did not perform or even where the AI actually performed, right? Whether the sensitivity and the specificity of the algorithm is as per what was declared or what was found to be in the FDA or CE studies, right? It has that AI accuracy not dropped further. So those are very important things that we have to monitor. In fact, what we also do is all the cases that are being read by the AI, right? There are almost close to 20,000 exams every day Qure algorithms are looking at. So subset of those exams every day is also reviewed by a panel of radiologists just to understand, if the AI is actually understanding, is making right decisions or not, right? So not just sort of doing post-market surveillance and all of this, sort of discordance meeting, but we also sort of take a sample of the exams on our end, right? Every sample, a sample of the exams that are read by Qure and those are reread just to make sure that the quality is up to mark on a daily basis. Next question is, does your deployment change care pathway? Is it possible to retrofit your intervention? Yes, it is absolutely possible to retrofit our intervention. Does it change clinical pathways? Not really. In some places, we are seeing that, yes, it is changing. A lot of, I would say in tuberculosis eradication, that's one place where we have been working possibly for the longest time. I think that's where we have actually changed. We have got a WHO approval to actually use the Qure algorithm in terms of sort of having a direct automated screening, right? You don't need a human intervention for any of the chest X-ray based screening or triaging for tuberculosis. So that's the kind of impact we are sort of striving for, where we have completely changed the pathway, right? That there was now you can have the chest X-ray done. The AI automation AI reports comes in almost 20 seconds or so. As soon as the AI report says it's positive, you send the patient for a sputum test or a gene expert test, right? So that's something which is revolutionary, right? Earlier, entire process would take almost good 10-15 days, right? Because there's a radiologist who would have to look at the exam. By the time they come back, they have to call the patient back, and there's like a good 10-15 days that is lost in diagnosing the patient from the first they had the X-ray to their final exam. And with this particular way, with the WHO endorsement, we have now been able to change that to 1 hour, right? Patients come in, they have their X-ray, sees positive within 20 seconds. You send them for a sputum test, get a result in 40 minutes. Your entire TB diagnosis is done in that 1 hour, right? So that's the kind of impact we have done. But in some of the other places, for example, in some of the other countries where we are working on other disease areas, we are not actively changing the protocol as of so far. The AI is sort of in those places also acting as an independent decision maker. Is an augmented decision maker, right? So it's basically augmenting the decision of the physician or the radiologist to make more accurate decisions. So there are both the sides, right? The places where we have changed some protocols, and places we haven't. And we see places where we have changed protocol that required a lot more clinical evidence, a lot of work with WHO to actually change those protocols. Whereas in some of the other places, it's acting as a decision support. So in that case, it's much easier. Okay, I think it's almost close to the end. So I'll just quickly wrap up with the last question. What does your system bring to a clinical process? For example, improving quality of decision-making, clinical system, automation of manual process, something else. In your opinion, clinicians perceive the gains to the extent you foresee. So what can you do to build consensus on the impact? So yeah, I think in terms of impact, what we have been doing is a lot of actually improving patient outcomes. That's the core of what all of us are trying to do here. But that happens in a lot of ways. I think one part is obviously improving the workload and the manual labor that normally radiologists or physicians have to put in terms of detecting, right? I mean, a lot of manual labor goes into sort of looking at a lot of normal chest x-rays. So can the AI just take off that workload? That's honestly one of our very big use cases at Qure. Sort of reducing the workload, improving turnaround times for radiologists so that they can report scans much quicker and more accurately. Apart from that, a lot of that also improves, for example, in better or earlier diagnosis of patients, right? So for example, in lung cancer, we have been working in almost close to 30 plus countries where we are trying to detect early lung cancer in stage 1 or stage 2, as opposed to what is done in stage 3 or 4 as of today. So there's obviously that kind of an impact as well, that we are trying to do in better diagnosis of patient, earlier care. There's also timely care, right? One is obviously earlier detection, and then there's timely care. Timely care is, for example, in stroke patients, can you sort of help AI do a quicker intervention, right? A thrombolysis or a thrombectomy being done then and there. So that's the kind of impact that we are sort of creating, I mean, which is a combination of all the things, right? It's reducing workload as well as improving patient outcomes and earlier detections. And yeah, I think in terms of consensus on the impact, there is definitely a lot of consensus that we are seeing now. As the AI ecosystem matures over a period of time, I think there's a lot of consensus that is getting built out in terms of what the AI is actually able to achieve. I think there's definitely a sign of the times in terms of what's possibly going to come next. And we definitely think there's a lot of maturity, more and more maturity coming into the ecosystem, people trying to understand what AI can do more for them. So there's definitely a lot more improvement. I think honestly, we are scratching the surface as of today. There's just a lot more to be uncovered in AI in healthcare in the next few years. And yeah, with that, I'll sort of end the session. All the best to everyone out here who's attending. Feel free to reach out to me on LinkedIn or Twitter if you have any questions. Thank you.
Thank you, Rohit Ghosh. To watch the complete club meeting on this topic, visit the link in the description below. Subscribe to the channel to get instant access to all the podcasts. Follow us on social media through the links available in the description below. Thank you all for spending your time in listening to this week's podcast. Look out for a new episode every Wednesday, published on Google Podcast, Spotify, and Apple Podcast. If you are interested in hosting your podcast with us, fill the form available in the description below. Thank you once again. See you next time.